Good afternoon, and welcome to today's program titled Transforming Social Risk into Real-Time Action, a Unified Approach for Payers and Providers. My name is Marie DeFreitas, and I'm the Senior Finance Editor for Health Leaders and your moderator for today's webinar. So today's program is sponsored by MedeAnalytics. Thank you to our sponsor and to you and our audience for giving us your time and attention. Note that an on-demand version of this program will be available approximately one day after the completion of the event, and this can be accessed using the same login that you used for the live program. Before we get started, I just have a few housekeeping details. First, to ensure that you can see all of the content for today's event, please maximize your event screen window and be sure to adjust your computer volume settings or your PC speakers for optimal sound quality. Second, you will find a resources list for today's webinar in the upper right side of your screen. Here we have listed the webinar slide deck and additional materials for you to interact with. Third, at the bottom of your console are multiple widgets you can use. If you want to submit a question, you can click on the little Q&A widget. It may already be open and appear on the left side of your screen. You can submit questions at any time during the presentation. However, just please note that all questions will be collected and shared with our presenters to follow up after the event. If you experience any technical difficulties today and you need help, please click on that little help widget, which has the question mark icon, and this will cover all of your common technical issues. Finally, it is my pleasure to introduce our speakers for today's program. So first, we have Megan Bell, who is the Senior Vice President and General Manager Provider at MedeAnalytics. We have David Wolf, who is the Vice President of Product at MedeAnalytics. We have John Zimmerman, who is the CEO of Hold-On Solutions. We have Trina Williams, who is the CEO and co-founder of Socially Determined. We have Paul Messina, who is the Director of State and Local Government Principal Researcher at Mathematica. We have Kim M. Pierce, who is the Medical Director of Population Health for Ambulatory Care and Primary Care Physician at Independence Health System. And lastly, we have Carmen K. Wilson, who is the Director of Account Management, Enrollment, and Billing at BlueCross BlueShield of South Carolina. Thank you, everyone, for joining us today. And with that, the audience is yours.
Thanks, Marie. My name is Megan Bell. I'm honored to be your moderator today for today's presentation. Thank you for joining. We have a lineup of industry experts from our partners at Socially Determined, Mathematica, and Hold-On, as well as customers from BlueCross BlueShield and Independence Health System, who will be discussing how we can take critical socially determined health data paired with integrated technology to bridge the gap between payers and providers to deliver seamless, actionable data that is proven to improve in clinical outcomes and in reimbursement. So with that, our first question for today, and who I'm going to kick it off with, is Dave Wolf. So Dave, tell me a little bit about why we're here today, right? So socially determined risk into real-time action. What's the real problem in the industry and how are we solving it?
Yeah, thanks, Megan, and good afternoon to everybody. I think I'll answer the question with a question. If you think about your own personal care over the last year, how much time did you spend with a provider, and did that provider have the tools, the insights, and the information that they needed in order to help you with whatever your ailment was? As a personal example, a couple of years ago, I had an ER visit that turned into an inpatient setting. My next visit with my primary care, he questioned, I see that you were in the hospital for a bit. What happened? And so to me, the most important thing that we're trying to solve here is how do we get that real-time information into the hands of individuals that can action against it? So a lot of the focus that we're going to have today is around real-time action. Now we're going to couple that with a little bit of a very gnarly data set being SDOH, or social determinants of health. And for those of you who have ever played in SDOH data, you know it's very difficult to deal with, and how do you combine it with other data? So hopefully through the course of the conversation, you're going to see there's a lot of other problems and opportunities that we'll get into, such as how do you identify the right interventions, how do you measure that clinical performance, how do you determine that ROI, et cetera. And you'll see that, but I'm going to kind of focus on data for an example as what's the problem and the root cause. Right now, all of our data is very dispersed across different EMRs, different systems, et cetera. That data is also very delayed by the time it gets from the action to the individual that can action against it. It's typically a report or a time delay. And so one of the major problems that we see is we have data everywhere, but in reality, we have data nowhere because it's not where it's supposed to be and in the form that it's supposed to be in. So hopefully, as you kind of start to hear some of the experts that we've gathered together today in this ecosystem of SMEs, we'll pick up different types of tips and expertise that you can kind of leverage when you're looking at, in this particular case, SDOH data and getting into the point of care and then getting a financial return on that type of intervention and being able to apply that across multiple different types of use cases beyond SDOH. It's just a really good example because, as I said before, the data is gnarly. What you'll also start to learn about through the conversation is how do we go about combining and curating that data? How do we develop those interventions? How do we make those recommendations? And how do we track them over time and then truly help you understand where do you put the limited resources that you have to have the biggest impact available? So problem is the main data is not real time and data is very difficult in this particular example, Megan.
Thanks, Dave. So I'm going to use your word gnarly and transition over to Trinner. So Trinner, what makes socially determined data different than anything else out there in the industry?
Yeah, thanks, Megan. And Dave, thank you. Dave used one of my favorite numbers as part of that. And I'm a family doc by background. The idea that a patient that we might see only spends an hour, right, as an adult inside of a clinic, a physician in here or PA given year, which means 525,000 plus minutes outside of that person's care. And for us to think in healthcare that we can really understand both the support systems that somebody might have, but also the barriers and challenges that they face every single day that are in their way of achieving what they hope is optimal care, I think is real. And so we've at Socially Determined have been in the business of quantifying the 525,000 minutes and quantifying people's lives. Again, the risks, the challenges, the barriers that are in front of them. We do that. We work with 3 types of data. We start with over 40 sources of open public federal data from the American Community Survey and the census, but the CDC and USDA, HUD, HRSA. It helps to give us real context around what's happening in communities across the country, and that's de-identified data. It's not enough, though. So we marry that with what we call commercial business data, or data about every U.S. business in the country. We do it so that we can understand access. So we want to know, like if you think about healthcare access, where's every pharmacy, federally qualified healthcare center, hospital, independent health system, like where are all of these places? But we also think about things like food access. Where's every grocery store, fast food restaurant, convenience store that takes SNAP benefits? And we measure time and distance to each of those access points. And the third really important part that's represented in the bottom 2 cylinders on the left is identified consumer and financial data on about 265 million people. So things like estimated household income, do I own or rent the house that I'm in? Do I own a car? How many people live there? Language spoken. And we take all of that data together and we do a couple of important things. We first want to understand at a community level, based on where somebody lives or where a population is, what risk are they exposed to? And then secondly, at an individual person level, I want to know what my personal risk is. So we do that at a community and a person level. Those 2 things by themselves, Megan, I think are differentiating. Importantly, that middle 7, those 7 categories, rather than creating a singular social risk score, because it's really hard, if not impossible, to address sort of global broad social risk. I want to try to solve for food insecurity or housing instability, transportation. So we create risk scores and other metrics around 7 different social domains that you see there right in the middle, from finance and food and housing as part of that. That is helpful and differentiating. Again, it's not enough, because part of what we do is we think about how to break down things like food insecurity. So we know, is it likely lack of accessible, healthy food that's driving somebody's food insecurity, or affordability issues? And as Paul and Carmen and the team started to talk about the work that they're doing, knowing that type of information and those insights change the way that you think about intervening and acting, right? Because I solve for affordability issues differently than I might solve for accessibility. So that creates the foundation and understanding. To be clear, and to me, this is the exciting part of this conversation with everybody, and especially Medi on the line. social risk data, our data that we provide, should not be used by itself. It's the integration of that social risk data with clinical data, with the disease quality gaps, information about cost and utilization, where people have gone for care, so that you can start to see the impact of social risk on utilization, on cost, on quality measures as part of that. And that being said, what we have found every day of the week and twice on Sundays is there are more problems for people to try to solve than they know what to do with, right? And so you've got to have the ability to be able to use data to drive an informed strategy around prioritization and stratification. You got to believe that there's a return on investment and a return on value as part of that. And for us, I think that's why this relationship and the ability to integrate both the data, but also a process of measurement with folks like Paul and the Mathematica team become vital.
Yeah, it's definitely not a one-size-fits-all strategy and approach, right? And I think to your point, the complexity of the data makes those very scenario-based. So Paul, I'm going to come to you. Based on, building on what Trinner just kind of described there, there's a lot of different aspects to this data. So can you talk to us a little bit about what challenges have you seen in implementing an SDOH strategy?
Yeah, thanks, Megan. So for those of you who may not know, Mathematica is a research and consultancy firm, and we have experience working with the accountable health communities model, the 1115 model. And so through that, we've understood how the social risk data operates and how it is implemented in the real world settings. And like Trinner mentioned, we realized while working with socially determined that a major challenge that gets overcome through socially determined data sets is a way to quantify risk. And I think what Trinner undersold a little bit is that socially determined can give you factor analyses. So they are the subcomponents under any risk. So it tells you, oh, if I have food insecurity, what is driving that food insecurity, right? It's not enough to assign a number and a risk factor, but like, what is actually driving that problem, right? So if you can figure out what's the root cause, you can then start thinking about interventions that are at the individual level to try to improve that situation. So I think the first challenge is understanding risk, which socially determined does an exceptionally good job at. The second part is where Medi comes in. So once you know that risk, you can then integrate it with other data sources so that you get a more holistic picture of what's going on. So Medi's ability to integrate those data are really important. Then that's where kind of Mathematica is stepping in, and we're saying, okay, well, we've got risk. That's great. We've got a lot of information about utilization and cost. That's awesome too. But how do I know how to connect an intervention that resolves a problem that we know exists such that we get a return on investment and improved outcomes, right? That is the big challenge. So I think we're at the precipice right now of where we can take these data and start asking that question. So what Mathematica does is we're able to look at the literature on social interventions and figure out what are the characteristics of individuals, may it be disease states, maybe it be their situations in life, that they would need a type of intervention that can resolve that issue, right? So we're going to do that matchmaking for you within the system. We're going to do that. And then we're going to say, hey, given what the literature says, we can reasonably expect this band of a return on investment if you take the right steps, which means integrating the individual with the intervention and carry that out. And the beauty is we're also going to do this in a full cycle where we're going to give you the monitoring, we're going to give you the evaluation. So not only do you know that it's working, but you get enough information in time to make changes. And oh, by the way, we'll have a learning system. So we can see, oh, the certain disease state responds better when you have this type of intervention versus another. And so the more you use it, the better it gets.
Definitely making it more actionable, right? And so speaking of that, going to kind of transition into our partner, Carmen, at BlueCross BlueShield. And I have a few questions for you, Carmen, just based on everything we've heard thus far. But starting, let's talk about a real world example, right? You're servicing customers each day. How do the challenges differ on the payer side when related to SDOH?
Yeah, thanks for that. We're very excited to be part of this process. Just intuitively that social determinants of health are hugely impactful to our members, to our community members. they're impactful to the employer groups that we work with. From the payer side, you're a little bit more removed from the process than from the clinical side. I did this on the clinical side for a long time. And when a patient's sitting in front of you, it's easier to see exactly what's going on in their life, even though, as Turner mentioned, it's a very short period of time. They're still sitting right in front of you. On the payer side, you're removed from that process. And so trying to identify what is actually there and what you can do something about is really, really sometimes opaque. And so using this to be able to clear that and define what it is that's actually going on and how you can impact it is incredibly helpful. There's just, like I said, there's a little bit of a distance between the person and the patient and the payer. In an ideal world, if the payer's doing our job effectively, we fade into the background. You don't see us in your daily life. And so how you impact someone's health ultimately impacts their life from a distance is just a different scenario.
Yeah, absolutely. And I think, care and experience obviously are both impacts to that care, right? And so from a payer perspective, even though you may not see them all the time, it is equally as important, right? So talk to me a little bit about what issues your customers bring to you around this topic.
Yeah, so I work mostly with the larger groups, and they are very much interested in how they impact the health of their employees. They also understand that in order to do this, it's more than just paying claims and making sure that their blood pressure is right. When a diabetic person is newly diagnosed, that's a huge life-changing event for them. And having a conversation with someone around what foods they need to eat and how they need to cook for their family looks very different if they are right across the street from a farmer's market or a grocery store than it does if they're in a food desert or if they don't have the income level to purchase that food. And so being able to marry some of this together is very hard for them because the employers aren't in the daily life of the person outside of their job. And so they need us to help them figure out if their assumptions are real. Most employers have a really good idea of the people who are coming in and out of their workplace on a daily basis. And they have some assumed risk that they know enough about their employees to know, like, I can tell you this is an issue or this is an issue. But usually what they have is part of the picture. Everyone talked about a different set of the data. The medical team has a set of the data. The payers have a set of the data. We can tell you what gaps in care are there. And then when you add in the social determinant data and then you add in this ROI analysis, we are able to help them narrow the scope and validate their assumptions and narrow the scope down to what's actually actionable in the situation. So most of their issues are trying to figure out exactly what it is that they can go after and impact to help maintain the health of their employees.
Yeah, absolutely. Can we kind of dive a little bit farther into that? So can you kind of walk us through how you use this data to help drive outcomes and results for your customers?
Yeah, absolutely. The first of that is validating those risks and helping them narrow the scope. So when we do that with any group, a lot of this is relational. Every employer, every situation has its own nuances. They all have things that they find important and that we need to address with them. So some of this is just being client-centered, client-focused, and helping them have the conversation, talk it out with them to find out what their priorities are. Almost universally, people want to make sure that they're spending their money in the right place to have the biggest impact that they possibly can. So making sure that we can show them that there will be returns on this investment. And by that, I don't always mean money. A return on investment for an employer group may be making sure all of their employees have all of the preventive care that they need, closing all of those gaps. It may have a financial impact for their employees, being able to help them provide resources for things of that nature. And sometimes it's employee experience as much as it is anything, because the employer wants the employee to feel supported. They want them to feel like they're in a place that cares for them, and that will go the extra mile to do the things that matter to them and that will take care of them and their family. And so we use this data to help them get to the point where they understand what can be addressed. And then we help them identify what are those point solutions, what are the things that we can do to help them address it. And then we use this data to come back to them and say, it worked, or we may need to take another approach, look at it from a different perspective.
Absolutely. Thank you, Carmen. So then the next place I'm going to go. So when we started this, we talked about bridging that gap between provider and payer, right? So we just heard from Carmen on how we're doing this for a payer, but then how do we get that data and that seamless integration into the provider? So John Zimmerman, I'm going to pick on you. I think with Hold-On, this becomes very exciting, right? So time to action, time to value is very key, right? So how does integrated patient insights, or what we call IPI, shrink that time and focus efforts for the provider?
Sure, Megan. Thank you very much for the question. But before I start, big thank you to health leaders, and bigger one to MedeAnalytics for bringing this partnership and this panel together for this critical discussion about how to actually make a difference. So great question. And this is how we work with MedeAnalytics with IPI to bring it to life. Look at Hold-On, we believe that the greatest untapped opportunity in healthcare lies in activating all of the intelligence that everyone just heard about. But you got to do that where care actually happens, which is inside the workflow of the clinical teams and the various members of those teams. That's how we can start to move from insight to impact. And intelligence alone is just not enough. We've seen enormous investments just today, right, in investing in the data and in insights for social risk, but also from rich community level analytics and real-time stratification, the kinds of things that Medi brings to the table. But unless that intelligence reaches the people delivering care at the right time, in the right format, in the way that they want it, then we're just admiring the problem, we're not fixing it. So that's why this panel makes such a difference. So from our perspective, what we've been able to do is we've patented some, we call it sensor technology. It doesn't really require integration. It can do, but it doesn't require integration or extra clicks or gives you the need to go look for something. It brings it to you the way that you want. So everything you heard about can be formatted and brought the way you want. And it complements the existing systems that the people are already using. EHR, CRMs, payer portals, it can be anything. And what we do is we surface exactly what that care team member needs to know about that patient in that critical moment when they're both together in the same place at the same time, physically or virtually. So today we're doing risk coding, quality measures, medication management. Now with what is coming from Trenner and socially determined, we can look at financial strain, housing issues, food insecurity, as well as the kind of things like health literacy challenges that exist as well. And there's more, but based on what socially determined and the payer analytics, whatever they uncover is relevant. How do we know it's relevant? Well, we know it's relevant by asking people like Dr. Pierce, who's going to follow here and talk about how we work together. So Hold-On kind of works as the connective tissue, taking the analytic insights from payer data sources, MedeAnalytics, socially determined, and really placing them where they're in the hands of those care teams and the clinicians and social workers, community navigators, whomever has to take an informed action. That's how we activate the intelligence. And it's one solution across multiple health plans. We've figured out that, what the humans need to see, they can tell you. What software can do, can go get it and bring it back to them in a useful way, as long as you ask. So what we're doing together now with the information side, and now you'll hear about working with Dr. Pierce and company, we think we're in the early days of creating a living intelligence system for health. So we work not just with the health system like Dr. Pierce, but her key payers in the Pittsburgh area like Highmark, EPMC, Health Plan, Bridges ACO, and we've seen this system and this approach evolve. It's dynamic, responsive, and continuously optimized by the collaboration among those key stakeholders. And Dr. Pierce is now going to tell us, how it really works. And what she's going to talk about is not what's going to happen someday. This is happening today, and it's been happening for a while, and we're getting the pull and expansion from the various stakeholders. This is working. Please do more.
Thank you.
Thanks, John.
Sorry, Megan, go ahead.
No, it's okay. Thank you for being here, Dr. Pierce, and kind of just building on what John had kind of prompted you for. I would really love to hear from your perspective, from a provider perspective, how does this look in your role in care delivery?
Thanks, Megan, and wow, thanks, John. And this is so exciting to be a part of this panel and hear all of this. And the thing I'm hearing is the activating intelligence and collaboration. So at Independence Health System, our journey really started with a simple but a very critical goal. And that was, how do we support our value-based care programs and improve patient care by getting the right insights into the hands of the right people at the right time? Insights that we can actually use. And before we did anything meaningful or to kick this off, we needed to get everybody aligned. And that's all our parties. We didn't assume what we knew what would work. We needed to listen to all of our partners. We listened to our care coordinators. We listened to, I'm a physician, we listened to our physicians and providers, our population health team, our health plans too. John will tell you our meetings are mega meetings with mega people. But what we heard was clear. It had to be easy, it had to be timely, and we had to make it relevant. We co-designed our program aligning and collaborating with many people to work within our existing systems and support our existing workflows. We were not to be disruptors. We needed to enhance it. So when Hold-On delivered the insights along with our EHR in environments alongside tools that we had for our care team we're already using, we really were able to make that adoption take hold. And we saw measurable improvements by this. We've improved our closing care gaps. We've done amazing things with closing care gaps and coding with our RSA program and medication adherence. And that's what makes this so exciting, because we take the analytics from both our operations and validating them through our payers. So we work hand in hand with our payers. I know that may be heresy to some people to say that we work together, but we do. And our health plans have been able to help us actually see where the impact is and where more improvement is needed. So together, we just don't act, but we learn from each other, we iterate it, and we've had those proven results. Improvements in our risk accuracy, improvement in our quality measures, improvement in medication management, and basically improvement in our care teams as well. We're not having shifting papers going all over additional care teams. We're putting it right within the workflows. And we're actually really excited to be a part of this. And thank you everyone for working together with this, because we're looking forward to working with this team to have the additional improvements with SDOH related outreach and insights, actionable insights, right? We know that patients may have trouble. If you're worried about where your next food or if you're going to pay the rent, you're probably not going to be able to pick up that medication. Eliquis may be way out of the price range for your atrial fib, and then you're going to have a stroke, right? So that's important information to know, and we're excited to be a part of some of this. our team's mission, and I could go on forever, so I'll be brief, but really our passion is taking care of our patients and making their health and their lives better and improved. So this information with socially determined and our patients improving their understanding, we're really excited to be able to apply these insights and collaborate and continue to improve our insights and be able to take care of our patients better.
Absolutely, Dr. Pearson. And I wouldn't call that heresy, I would call that pioneering, right? I think the more that we work together with our payers, the more seamless the overall experience is for all involved. So congratulations for your team and what you've done, and I can't wait to see kind of the next phase of it. So kind of taking all of that, right? So we've heard a lot about the power of the data. And Dr. Pierce hit on this a little bit, and Dave Wolf, I'm going to come back to you, is how do we bring all of this together, right? So we've talked about the complexity of the data and then bridging that gap with integration and technology between the payer and provider so that they can talk together. So talk to us a little bit, how does Medi fit into this puzzle, and how does MedeAnalytics make all of this happen?
Yeah, this is a lot of the sausage making, but it's highly important into seeing the overall value that gets realized and delivered into the various different clients that we help support. So I'll go back, Megan, to kind of where I started with your first question on the data part of things, right? We as Medi over the last couple of years have developed a very intentional, purpose-built health fabric. And unless you're into technology and analytics, you might be like, what is a health fabric and why is that important to me? And the easiest way to think about it, and Trenner hit on this earlier, is any one of the data sets that we've talked about is valuable in itself in isolation. But where you really start to unlock the true value of that data set is when you start to combine it with other pieces of data. So think of health fabric as different threads of data that we are starting to weave together. And as you do that weaving of data, you create a more holistic, a more rich picture of what's happening with that individual, that total cost of care, if you will, whether it's a behavioral health, an SDOH, pharmacy, medical, et cetera. You can start to glean different opportunities when you have all that data being acquired and enriched. And so that's probably the main thing that Medi brings to the table to kind of kick this off, is bringing in data from our clients, combining that with SDOH data and identifying where we have those opportunities, and then having the team at Mathematica and Socially Determined put together those pro forma ROIs and projections as to what kind of recommendations should we be making, right? So that's all driven by the data. So that's that health fabric, and even to a point, some of our data science factory where we enable that data through various different AI models to drive information down specific workflows, such as with John and what Dr. Pierce talked about. Or it could be providing different types of analytic insights, such as creating dashboards and whatnot around what those opportunities might be. So that's that left-hand side of the page that the Medi Health Fabric kind of pulls together and enables how that data comes to life. Now, that's all kind of behind the scenes. Typically, providers or our payers, our end users of the tool are in more of that act phase. So you'd heard John Zimmerman talk about how do we take the data and move it into more of an action orientation. And you can do that in a variety of different ways. Paul talked about we need to be able to maintain and monitor what's going on with those SDOH interventions over time. So being able to see dashboards of what interventions you put in place, where do you have target KPI performance, and where are you in relative to those KPIs? Great way to use some of those standard integrated analytics. On the flip side of that, a lot of clients, quite frankly, aren't sure what exactly to do with the information. So there's a lot of help coming from how we go about putting together that pro forma ROI, but then also the Medi Managed Services team will actually come in and help consult of designing the right type of intervention, knowing our tools, our data interoperability, our analytics the best. How do we give you the right kind of package to truly light up the value that you're going to see utilizing the solutions that we talked about today? And then finally, where that all kind of ends and kind of the pot at the end of the rainbow, if you will, or the golden goose that people are searching for, it's how do you impact that value realization? And now this is more of a general slide that we tend to use to show you the different areas. We've touched upon a few of these. The tool that John mentioned before can go across risk and quality. We just happen to, again, use the gnarly data set of SDOH to help everyone understand the full end-to-end continuum and value that gets created. The last thing I'll kind of say on this slide, Megan, and I'll kind of give it back to you from there is, I don't want to underemphasize the accretive ROI, like especially with SDOH information in the times where, we've talked to clients or prospects around how do they utilize SDOH, and how do they have different types of strategies. There's a lot of like, I don't know, show me how this is going to have a financial impact so that I can justify it. Or quite frankly, how do I take the limited resources that I have and put them into the areas where they're going to have the optimum impact? And so we can do that through various different tools that we have available. So that was kind of a front to back answer for you, Megan, but that's basically how we bring this to light with the sausage making behind the scenes.
Oh, that's great. And I think I have one question to build on that. SDOH isn't a new concept in the industry, right? And so my question to you is, how do you think Medi and the group on the phone separates themselves from the solution from others in the market?
How much
what
time
are
do
those
we
differentiators?
I think there's quite frankly 5 or 6 that I could rattle through. Just the simple best of breed of SDOH data with Mathematica's actuarial rigor on top of the tools that we use with John and Holon of getting this into the hands of physicians like Dr. Pierce and the clients of Carmen at South Carolina, right? That end-to-end of getting that information in a turnkey program using best of breed, being able to plug and play very quickly, and having all those connections and those data transfers pre-established. So there is a very small time to value that is created through just this particular example of a use case that we've talked about today with SDOH and the real-time care into a provider setting. That would probably be
using I apologize. Going back to Trinner's, not one size fits all, right? Yeah. So creating kind of that customized approach in the data, but also following that all the way through from both provider and payer, it really kind of completes that full circle.
Mm-hmm. Maggie, can I jump in? Pull down?
Yeah, absolutely. Yeah.
So I love what Dave said, because for any of the either payers or health systems that are on the line and listening or will listen to this afterwards, like most of them are probably really struggling with point solution and vendor fatigue, right? There's just so many things that are out there. What Dave said, I don't think we can emphasize enough, which is the fact that these connections, the data connections, the workflow connections have already been built, like so that you can start to pull all of this disparate information, the insights together, to have guidance from like Mathematica to be able to say what to place your bets on. You only get so many chances at this. So, but just that speed to value is such a differentiator, I think, in the market, rather than saying to a health plan or a health system, hey, we can work with anybody that you have, right? We can make all of this work. To actually have those connections done and ready and come in as a complete end-to-end solution, I think really matters.
I agree. Absolutely. Okay. Kind of as a next step here, we have about 20 minutes left. Would love to open it up to the audience to ask any questions. I just want to, while those questions come in, thank the panel today for your time and insight, but also everyone who has joined. I hope this has been very helpful. And so what we're going to do now is we're going to kind of go into a Q&A round and make sure that, everyone who attends today has a clear picture of this, as well as if you have any other questions or would like additional information on this, there's an email address on this slide, info@MedeAnalytics.com. Feel free to shoot us an email. We will absolutely connect you with the appropriate resources and get back to you. So Dr. Pierce, I'm going to start with you in the Q&A. So there's a question that says, Kim, when you say it is impacting your risk scores, are SDOH included in your risk scores?
Currently, we are not. including additional SDOHs in the risk scores. However, they are incorporated in risk scores. So when you look at CMS and they look at the HCC, the hierarchical condition categorical of diagnoses, that's a mouthful that I always have difficulty with. But when you look at SDOHs, they're included in your geographical regions, and there are value-based care incentives with our payers that are aligned with our SDOHs, and there's also care coordinator fees. So they're very important to actually track and be aware of, and can actually help with some of those alignments of when you're looking at someone's overall cost per month that a patient costs. It definitely increases that care cost. So there's some returns on investment, and perhaps the other people in this group that could speak to that better, so I'll defer to them. But in addition to that, you'll see supplemental programs, meal delivery programs that will come out, and extra benefits that some of our payers will include. But it allows us to better predict our costs. So we're kind of really excited about this opportunity to be able to put this within the hands of all of our providers, so that we can actually have actionable insights to improve the lives of patients.
Absolutely. Thank you. Okay, the next one is a two-part question, and I'm going to open it up to anyone on the panel who would like to respond. So, two-part question. I may have missed this, but when you talk about real-time action, what's the optimal window between identifying a social risk signal and implementing an intervention before it becomes too late to meaningful impact outcomes? That's part one. So let's start there.
I can take that one quick, and then Trenner, you can jump in. Yeah. So from the researcher and literature perspective, this is why, again, I'm going to use gnarly again. Like SDOH is gnarly because oftentimes the risk isn't totally solved. You're trying to mitigate the risk as it occurs over time. And anybody that's dealt with SDOH risk, there's a fluctuating cycle to it, right? And that's why I think what Socially Determined has done with those root causes, again, I'm going to get back to that, because like if your root cause for a lot of your underlying social risk is economic instability can be a paycheck to paycheck thing, right? So maybe you have a food insecurity towards the end of the month because you haven't been paid yet. But then when you get your check, you can then use that for rent or food, and then you get a different like disaggregation of what the risk really is. So I think the window is very dependent on both the person and the risk. So figuring that out, you need to be able to understand that and pinpoint it, and then tie that to an intervention. So that's just from the literature perspective. And what we're trying to do with Mathematica while we're working with this group is to help you better understand, given these underlying risks and what's happened with this natural fluctuation cycle, when's the best time to intervene and how.
Yeah,
absolutely.
Just to build a little, oh, sorry, go ahead, Megan.
No. Go ahead. Well, let me ask the second part of this, and you can build on the first part into the second part. Second part of the question was, how do you handle the social risk paradox, where the populations most in need of interventions are often the least likely to engage with digital health tools or provide complete data?
It's a great question. So a couple of things I would say. First of all, one of the fascinating things, and Carmen is such a good example of this. When I started the company, I thought primarily we would be talking about folks who have Medicaid, right, or dually eligible, right? Sort of the natural inclination to think that. More than 50% of the 20 million lives that we touch are commercially insured. I think that's fascinating in and of itself. It is generally, though they're the lower wage or mid-wage workers that are part of that, but so much of our commercially insured population are fragile, right, when we think about it, right, as housing costs and everything else has gone up in their lives as part of that. So when we think about like the paradox, first of all, I think they're really great tools and companies and partners that have demonstrated that those folks that we may have assumed may struggle with digital tools actually are using them. And I think a lot of that gets into the workflow. And then you put on the fact that if you can deliver this data, like with Hold-On, like to Independence and Dr. Pierce, right, at the point of care with providers that people already trust, I think you have a chance to change the way that a person, at least what we see, a patient whether you think of them a member or an employee, like actually engages. And I don't think there's a higher trust quotient than with that provider. And I'm sure I'm biased because I'm a primary care doc, but like, I think that really matters, and that helps to bridge that, maybe that SDOH paradox around that as well.
Absolutely. Dr. Pierce, I know you're answering this one in the chat, but I'm going to ask for the larger group. So there's a question that came in around management practices. How do you promote responsibility to the employer, the ability to judge the quality and productivity, to the employee, i.e. quality of work generated related to performance of staff, and to the public, or balance scientific principles, requirements of criminal justice system, and the effect on the lives of the individual?
Megan, was that
maybe on mute?
Sorry.
Yep, for you. That's okay.
How do you, sorry about that. How do you balance? I'm trying to make sure I understand the question. How do you balance between the different parties, the employer, the
correct. So the employer, the employee, and then the public or the patient. Yep.
Well, I honestly think and this may be my own personal view, but it seems to work. You focus in on the patient, right? And everything follows from there. So I've found that most employers, our providers, our care teams, we're all trying to do the right thing. And if we make it easy to do the right thing, you've got a triple win, right? So that may be a simple answer, but that's how we look at it.
That's you being a pioneer for sure. Okay, next question is for Carmen. So Carmen, for payers, what are they doing to execute? What are they doing executing when a member is identified with a possible unmet social need?
Yeah, thanks. I was just trying to answer this one in chat, so it's much easier to do this one talking.
No worries.
This one's going to be hard to answer because it's going to be different. Every member is different. Every situation is different, and so when you talk about an unmet social need, that could be a huge range of things. We have had members who are new employees who all of a sudden have some traumatic life event, and an unexpected ill family member ends up in their house, and they're trying to take care of them in the midst of everything else, and then their behavioral health is impacted. And so what I would do for that member versus what I would do for the member who their car broke down and they don't have a way to get to their doctor's visit or to to their practice would be very, very different. And so that's a very vague answer and probably doesn't really give you the clear guidance that you're looking for there. But some of that is the variance in what we have to offer and what we can give people. And the data is really what would drive our intervention in that manner, because we would have a better picture of their entire life. We would have a better understanding of what they needed to be able to meet them there. Someone talked earlier about the people who need it the most are often the ones that aren't going to engage digitally. In that instance, we may have somebody show up at the door. I mean, and so it really is and can be individualized when you have what you need to make those decisions.
And Carmen, definitely. I would love you to maybe tell me if I'm speaking too much or overstating, but I know with our work together, some of this, which is like if you have existing benefits or if you have existing partners like that you all work with that are intervention partners, I think that ability, and again, part of that is the prioritization, right? That your employers have to like what matters to them. So it may not be solving every single unmet social need, but for ones where you've got tight alignment around an existing benefit or tight alignment around a vendor partner that you already have, knowing from a workflow standpoint that your care managers, your team, like that connection can happen helps to facilitate. And then as you start to look at the data, you can say, well, what other benefits, what other partners, what other community resources do we actually need to put in place? Because now we understand the risk of these populations even better. Is that a fair?
Yes, that's exactly right. It's more often than not, the fact that they don't know that the benefits are there, or don't know or have the resources to access them, or there's a barrier there that needs to be addressed first.
Yeah.
It's like your hierarchy of needs. You're not going to focus on what you need to eat when your roof is caving in. And so those types of things, it's that same sort of scenario. But you're right, having all of these things in place allow us, once we've identified what it is that we want to, or we feel like we can address, then the rest of this sort of falls into place.
Megan, may I add a piece that Trenner, Carmen, Kim all talked about, because it's terribly important and often missed. So first of all, big kudos to Trenner for using great words like with and, right? There's no one thing. And the real key here is the alignment. Taking a little bit of time and understanding who and what needs to be aligned together is the most important first step to performance improvement. And I think because of our complex ecosystem with these great questions, it really forces us to do that. And Trenner, you did it just naturally because you know how important it is. So I think that's a great takeaway from today's discussion.
Absolutely. Thanks, John. Okay, we have one last question. So Dave Wolf, I will ask this one to you. If I wanted to use this from contract signing to beginning to execute, how long is that?
Obviously, a lot of variables go into it. If it's a existing client, we already have some data and we're expanding it, that kind of thing. But like in a general sense, it can go as quickly as you can run. And what I mean by that is I've been able to take in data and start to show analytic insights within a 7-day time period. So I don't have a concern from taking the data given some of the health fabric technology that we covered before. Getting the rest of the work done of identifying the social risk factors and then identifying the cohorts that you want to be able to push out, like that is a lot more on the discussion with a client as to how they want to see that done. So like as a really good example, there was a question earlier to Dr. Pierce about SDOH data and HCCs. Like we're utilizing SDOH data today because of it's, again, a gnarly data set. It's a good story to understand what is the value that can be created through this series of partnerships. But the pipelines, if you will, of how we feed information to the Dr. Pierces of the world, we can swap out different types of data sets based upon what is necessary. And so where the magic really starts to happen is you have that SDOH data and the HCC data and start to combine them and create those cohorts where you have maximum opportunity and push those as like a primary tranche, right? So there's a lot of work that goes into figuring out who do we want to identify and then get them into the appropriate areas.
So definitely an evolving project, right? So start with a use case and continue to evolve. Okay. All right. Well, with that, those were the rest of our questions. I'm going to hand it back over to health leaders to wrap us up.
Awesome. Thanks, Megan. So that is all the time we have for today. I want to thank our speakers once again for an excellent discussion and our sponsor, MedeAnalytics, for making the whole program possible. And finally, thank you to our audience for participating today. We really hope you'll join us in the future for another Health Leaders webinar. And that concludes today's program.